Hello, everyone, and good afternoon. I am Dr. David Ninen, and it is my pleasure to introduce today's sixth and final session for the 2023 Mid-Year Seminar, First Take Your Own Pulse. We are grateful to be joined today by Dr. Lilach Rothschild, Jessica Goller, and Christoph Ladowski. Dr. Rothschild is an associate professor of clinical anesthesiology in the Department of Anesthesiology at the University of Illinois College of Medicine, where she practices pediatric anesthesiology. She also provides pediatric anesthesia services to Shriners Hospital for Children in Chicago. She was appointed the Wellness Champion in the Department of Anesthesiology at the University of Illinois and spearheads many anesthesia resident well-being initiatives. Dr. Rothschild will begin the session with her lecture on compassion versus empathy, what's truly to blame in burnout. Please join me in welcoming Dr. Rothschild.
Thank you, everyone, and thank you to the leadership for the invitation to speak. And also, thank you to all of you for staying till the end, especially for something that maybe many of you might consider a pretty touchy-feely subject. And also, if you, even just by the look of the first slide, maybe a little bit different than the other presentations so far today. I would also argue, though, that the topic of compassion in healthcare and in medicine is probably one of our biggest drivers for going into medicine, and also is something that I hope at the end of this you can think about as a way to turn to help prevent burnout and promote your well-being. I have no conflicts of interest to disclose. Objectives for today will describe the differences between empathy and compassion, identify ways in which compassion and self-compassion promote and support our well-being, and recognize that compassion and self-compassion are both skills that can be cultivated. So I'm going to start off with a story. And this story stands out in my mind because it was really the first time where I saw and recognized the impact of my compassion training. And I should have started off by mentioning that I completed a one-year teacher certification program through Emory University, through the Center for Contemplative Science and Compassion-Based Ethics, where I trained. It happened to have been on Zoom because it was right at the start of the pandemic. It started in 2019 and then went through 2020. But this particular day was kind of my moment, where my aha moment, where I realized, wow, this is making a difference for me, and it's making a difference for my patients. And so on that particular day, I was assigned to the peds urology room. And for those of you who do peds, you can imagine that that was a very busy day with lots of running around, lots of introductions, lots of inductions, emergencies, sedations, et cetera, et cetera. And it was getting towards the end of the day, and we were wrapping up our second to last patient. And we got a call in the room from the pre-op nurse. And all I heard then was what the circulating nurse shared with us. And she told us, I'm just letting you know that the next patient and their family are really pissed off. They're really ticked off that they've been here all day long and that nobody's even bothered to speak with them. To which the surgeon in the room immediately responded and said, you know what? They can go. Nobody's forcing them to get care here. I'm not holding them down. If they don't want to wait, that's not my problem. I'm doing the best I can. So, and kind of dismissed it. And in that moment, I was like, oh, okay, I'm gonna channel what I've learned and what I really feel to be making a difference for me. And so I went outside and I met with the father and I introduced myself. And before I could even finish introducing my name to the father and the young child, the father launched into a litany of complaints of how he had been here all day, how nobody had even bothered to come give him an update, how nobody had bothered to even give him a glass of water or any kind of food, and that he wasn't allowed to leave his child, and he was hungry, and on and on and on. And so I just let him finish his thoughts, and when he did, I then stopped and I said, I'm so sorry. It sounds like your day has been horrible, and I'm so sorry that we have contributed to this. And you could see that he just melted into his chair, and there was this sudden sense of relief. And I then followed with, you know what, before we even go any further, how about I go get you some crackers, saltines, and maybe some juice. And again, the mood softened and everything kind of just fell into this nice connection that I was so mindfully aware of because of my compassion training. And again, probably on any other day, I may have responded like the surgeon. I may have not even been aware that this was something that I was doing intentionally. But again, because of my training, this is something that I've come to learn to be kind of a superpower for me, and something that really fills my cup and connects me to patients and helps patients and also helps me. So we're going to start off with a couple definitions taken from Merriam-Webster Dictionary. So compassion, while there's no single all-encompassing definition of compassion, it's generally understood to be the response to suffering of another person and the desire to alleviate that suffering with action. So again, I want to highlight the desire to alleviate that suffering with action, a readiness to act. Compassion does not mean that we're sharing the suffering with the other person. Rather, again, it's characterized by feelings of warmth, concern, and care for the other, and the desire to help and relieve that pain. It is often said that compassion meets suffering with action, and this is the key. Empathy, on the other hand, very different, although at the core is required to feel compassion. Empathy is the action of understanding, being aware of, being sensitive to, and vicariously experiencing the feelings, thoughts, and experience of another, of either the past or the present, without having the feelings, thoughts, and experience fully communicated in an objectively explicit manner. Empathy is when we think of being in somebody else's shoes, right? Feeling what they're feeling. And the reason why I'm drawing this distinction between empathy and compassion is because in the literature from the non-neuroscience and non-psychology folks, you'll see these terms used interchangeably. And I really want to draw attention to this because they are uniquely different. And compassion, hopefully by the end of this talk, you will recognize that this is a skill that you can bring to your patients, and also something that can enhance your well-being and prevent burnout. So there are three types of empathy: cognitive empathy, emotional and affective empathy, and empathic concern. Cognitive empathy is having the awareness of another person's emotional state, whether it be positive or negative, and actually adopting that perspective to try and understand what they might be thinking or feeling. Emotional or affective empathy is attuning to that emotional state and being sensitive to that and connecting with that person. Feeling it in your own body, what they must be feeling. Empathic concern is really another way of saying compassion. So I'm kind of singling that out as very different, because when people generally speak about empathy, they're talking about the first two. They're not talking about empathic concern. One key piece in the experience of empathy is to have self-other differentiation. And that is to say, to have the ability to be in the presence of another person who is experiencing pain and suffering, and yet always remaining cognizant that that pain and suffering isn't your own. It's knowing that you're resonating with those emotions, but you're not taking them on as your own. And if we blur this self versus other distinction through excessive sharing of these negative emotions, this is what can lead to empathic distress. This is what can lead to burnout. And this is what's harmful, not compassion. So whether observing the distress in others leads us to engage and experience empathic distress, which is a self-focused emotion, versus empathic concern, which is an altruistic motivation, depends on this ability of self-other differentiation. Compassion fatigue is a misnomer. You're going to see it everywhere. If there's one thing I hope you take away from this, is that compassion does not fatigue. Compassion fatigue does not equal empathic distress. Again, these two terms have been used interchangeably in what I would call more lay spheres, not in the neuroscience world, and used to describe empathic distress, or compassion fatigue is used to describe that emotional and physical exhaustion that we as physicians may develop at some point in our career, 50% of us at least, in the form of what's called burnout. But there's pushback, and for good reason, from those who study neuroscience and psychology, because compassion is not fatiguing. It's not an exhaustible resource like empathy. Compassion fatigue is a misnomer because it often fuels the giver of compassion. When empathy fatigues, again, it's empathic distress, and this is because it's a strong and aversive and self-oriented response to the suffering of others, and leads to a desire to withdraw from a situation so as to prevent these negative feelings and emotions, and really just for kind of self-preservation and to protect ourselves. Dr. Tanya Singer, who is a world-renowned neuroscientist and has done a lot of work in the field of compassion and empathy, put together this beautiful chart that really draws the comparisons between compassion and empathic distress. Compassion is an other-related emotion, and empathic distress is self-related. Compassion leads to positive feelings, and empathic distress to negative feelings and stress. Compassion promotes good health, and empathic distress leads to poor health and burnout. Compassion is an approach and a pro-social motivation, and empathic distress is something that's related to withdrawal and is a very non-social behavior. So we're going to switch gears for a second and go back to the concept of burnout. And we know that burnout is a multidimensional syndrome stemming from many factors. First and foremost, organizational and systemic problems. Also, Amy Vinson, who's also a peds anesthesiologist, and wrote a great article in the 2021 edition of, or 2021 in Anesthesiology, said after reviewing and studying anesthesiologists and what causes burnout, that the single biggest factor in anesthesiology burnout is lack of support in the workplace. I think support is also very interrelated to compassion. So I'd like to focus on really the first two elements of burnout: depersonalization and emotional exhaustion. Depersonalization is often understood as the cynicism where we view and treat people as objects. We're unable to make that personal connection. I want to highlight that, again, compassion requires that personal connection. And then emotional exhaustion, which is really a precursor to empathic distress. Emotional exhaustion is when we have no fuel left in the tank. We don't have anything else to give. I highly recommend you all get a copy of this book. It was really kind of life-changing for me as part of my CBCT training through Emory. It's a very interesting read, and it was written by two physicians, one a physician scientist and the other who's a CMO of a healthcare institution. And the CMO had been charged with improving patient outcomes and also linking human connection to these patient outcomes. And so there was an extensive review of the literature that supports the idea that compassion has the power to improve patient outcomes and improve healthcare costs for both the patients and the healthcare system. And the book dedicates a large section and takes a deep dive into the benefits of compassion for healthcare providers and how compassion is associated with decreased burnout. And one of the things that actually is one of the mantras that you hear over and over in this book is don't get too close to patients. You know, let's, or I should say, this is suggested through some of the other literature, not as something that we should do, but something that you see often. You know, we need that better life-work integration, that life-work balance. We need to get away from the hospital. We need to get away from patients. I'm arguing that this is not the case, that actually we need to lean in and we need to get closer to our patients. So I think it's time to rethink the dogma of don't get too close versus leaning in. And it's time to really address this. Historically, even from the very beginning in medical school, students, we, now physicians, are taught don't get too close to patients. Keep that emotional distance. Protect yourself from that emotional overextension to reduce your risk of burnout. But again, the scientific data tells a very different story because the human connection can transform that caregiver experience for the giver of compassion, and it can trigger positive emotions and build resilience. And if we focus for a second on the patient's perspective, what kind of care do we think the patient would want to experience? And then if you take that one step further and ask yourself, if I were the patient, what kind of care would I want to experience? And I've straddled that fence multiple times over the last couple of years, somewhat serendipitously coinciding with my training, and I've thought about it a lot. And so, as we touched upon when reviewing the definition of burnout, we can appreciate and understand that there's an inverse relationship between compassion and burnout. That is, when there is high burnout, there is generally low compassion. Burnout crushes one's ability to be compassionate. However, one can't confer causation, only association. But many assume because of this inverse relationship that it actually means that burnout causes compassion to drop. That's not the case. If the evidence actually showed that don't get too close, too much compassion will burn you out, then we would expect to show a positive correlation. That is, when physicians experience high compassion, they also experience high burnout. I'm sharing this picture of Dr. Tanya Singer and Matthew Ricard. Again, Dr. Tanya Singer is an expert in empathy and compassion research, and Matthew Ricard is a French Buddhist monk and a longtime meditation practitioner and also a former scientist and translator to the Dalai Lama. He has been an incredibly important inspiration for Tanya Singer's work in contemplative science because he's logged more than tens of thousands of hours of meditation on loving kindness and compassion. And Tanya Singer's work has repeatedly scanned his brain while he practiced different types of meditation to investigate the plasticity of empathy and compassion in expert meditation practitioners. And they have found many interesting things. The experiments have shown that there is a core network in the brain that gets activated when someone experiences direct pain or vicarious pain. And what I mean by that is there were experiments that led to fMRI compilations, which you see here presented, where participants received either a painful stimulation to their own body part, or they were shown pictures, cues, or films that presented another person experiencing pain. And interestingly enough, both the vicarious experiencer of the pain as well as the person who experienced it firsthand had activation in these same neuronal networks. It's called the empathy for pain network. So what does that mean for us? It means that if we're engaging in too much empathy, and again, not compassion, that this can potentially elicit our pain pathways and potentially cause us undue stress and harm. Compassion, on the other hand, is very different again than empathy. Compassion activates the reward pathways on fMRI, and this is associated with affiliation and positive emotions, and leads to experiences of pleasure for the giver of compassion. The research studies have measured the functional, neural, and subjective responses to witnessing the distress of others, both before and after compassion training, and look to see what happens if subjects undergo compassion training. And the results demonstrated that the initial responses prior to training were accompanied by more activation, by both negative affect and more activation of the pain pathway, whereas those who engaged in compassion training had greater activation of the reward pathway and a muted activation of the pain pathway, or none at all. So again, compassion can offer us something. Dr. Richard Davidson is a neuroscientist from UW-Madison, and he also studies brain plasticity and compassion. And he says that compassion is just like any other skill. Compassion is no different than learning to play the violin or learning to engage in a complex sport, in that if you practice, you will get better at it. So again, compassion is just like any other skill. We can practice it and we can get better at it. The good news is there are a lot of compassion training programs across the country. There's one at Stanford, a well-recognized one at Stanford with a couple different programs, as well as one at Emory, and then several other options as well online. So if you're interested in taking a course or introducing this concept to your department, here are some of the courses that are available to you. All of these are secular in their design, but they have been influenced by Tibetan Buddhist traditions and incorporate contemplative focus on generosity and kindness. Again, this training was monumental for me at a time in my life where I think I was just coming to understand that I was really burnt out. This was somewhere about 11 years into my practice, and it's really made a huge difference. It does not change the systemic or organizational issues, but it does change my day-to-day engagement. And so compassion practice, what can it do for you? It can activate your parasympathetic nervous system. It can increase your happiness by activating these brain circuits. It can lead to a spike in endorphins that activates the reward pathways. It leads to an increase in oxytocin release and feelings of closeness and calmness. It reduces the stress response and has also been shown to reduce systemic inflammatory markers. If I were to do a PubMed lit search with the mesh terms burnout and compassion, there would be over 2,000 articles. So I didn't know exactly what to choose, but I chose this one because it came out of Emory. Although there's no financial disclosures. I just really enjoyed the program. And it looked at 132 students who were randomized to either compassion training, medical students, to either compassion training or a wait list waiting for their compassion training. And what they found is those that were randomized to the cognitively based compassion training, not surprisingly, found that they had more compassion by the end. But the other thing that they found is that those who were randomized to the compassion training also had reportedly decreased reports of their symptoms of loneliness and any depressive symptoms. And furthermore, they also found that those that had those greatest decreases were those that actually started off with reporting the most symptoms of loneliness or depressive symptoms. So again, this could be something to be utilized when we're already in that struggling kind of space. And I would be remiss if I talked about compassion without talking about self-compassion, because self-compassion is really like the cousin to compassion. You really need self-compassion in order to truly embrace and practice compassion. Because if we don't understand how to be kind and compassionate with ourselves, how can we possibly expect ourselves to offer compassion to those around us? So just like compassion, self-compassion is attuning to someone's suffering. It's attuning to your own suffering. And so self-compassion is compassion turned inward. And it's comprised of these three elements: mindfulness, self-kindness, and common humanity. Mindfulness is our ability to be in the present moment without finding too much connection to our feelings, thoughts, and experiences. So not really adhering to these different feelings, thoughts, and experiences, but just being mindful of them without any judgment. Self-kindness is what it sounds like, being kind to ourselves, treating ourselves with warmth, concern, and with unconditional love, just like we would to a friend who is struggling. And then common humanity is the concept of we're all in the same space, experiencing more or less the same things, maybe at different times. We're all going to experience setbacks. We're all going to experience failures. We all are vulnerable at some point or another. And so this is part of the common human experience. One of the great quotes that I like about self-compassion is that self-compassion is practiced not to feel better, but because we feel bad. So again, self-compassion is something that we can offer ourselves when we're feeling bad. Self-compassion benefits, again, numerous, can improve your resilience, can improve your sleep, can improve your motivation, improves healthy behaviors, leads to increased personal accountability, improves relationships, and can increase authenticity. There are also a lot of self-compassion training programs online through many different organizations, too numerous to actually list here. But I recommend this book, which was written by Kristen Neff and Chris Germer, and it's a workbook that's very easy to go through that helps kind of outline the ideas behind self-compassion and then skills that you can use to develop self-compassion for yourself. And this is a picture from March 18th, 2020, and I'm sure all of you can think back to what your life might have looked like back in March of 2020. And this was on the eve that my whole family gathered to drop off my dad at the hospital for pancreatic cancer complications. So you can imagine it was a pretty big deal for us. And we dropped him off. Obviously, we weren't really allowed to proceed into the hospital because of COVID. I managed to finagle my way in because my dad couldn't even speak. He was so weak. And so they let me up to his room and I got this picture with him. But what I want to share about this is that my dad spent the next 3 weeks in the hospital and he couldn't even pick up the phone to give us a call. And by some twist of fate, the first 2 oncologists that were on service were actually pulled off service because of exposure contacts. And so on the 3rd day, there was a new oncologist on service, Dr. Blaise Polite. He was amazing. And he made it a point to call me every day at 12 p.m. to give me an update on my father. And he was again just filling in. And when he was about to leave, so again just 2 days with him, he promised me that he would still call me every day at 12 o'clock, and he did that for the next 3 weeks. I'm sure we can all imagine that he was very busy, but he knew how much this meant to me, and he knew how much I was following up on everything that was going on with my dad, and that this was something that was going to help me. He was a giver of compassion. I would imagine that he felt very good about this, and I certainly received benefits as well. And I'm going to close with a quote from the Dalai Lama. If you want others to be happy, practice compassion. If you want to be happy, practice compassion. I know that we all went into medicine and anesthesia because we love people, because we want to help them. And I know that we all have compassion for our patients, and that sometimes the system can wear us down. My wish for you is that you can embrace the concept and deliberate practice of compassion, maybe after some training, and that you see it as an opportunity to offer kindness and also as another tool to support your well-being and prevent burnout. I hope that you're able to slow down enough in your days, just enough so that you can find these moments and seize the opportunity, no matter how small, even if it's just some graham crackers, to harness this superpower for yourself and your patients that will benefit you both. And so I hope your future leads to more graham crackers. Thank you.
Thank you so much, Dr. Rothschild. That was really great. Next up is Dr. Jessica Goller, who will be speaking on difficult conversations. Dr. Goller is an associate professor of anesthesiology and pediatric anesthesiology at the University of Nebraska Medical Center. She leads as director of perioperative services at the Children's Hospital and Medical Center in Omaha, Nebraska. She is also section chief of comprehensive pain medicine, a faculty senator for the University of Nebraska Medical Center, and elected physician on the Children's Specialty Physicians Board of Directors for Children's Omaha. Dr. Goller serves the AOCA as a member of the Board of Governors and chairs the Professional Education Committee. Please join me in welcoming Dr. Goller.
Thank you, Dr. Ninan. And I have a question for you, Dr. Rothschild. Compassion is contagious? You hope so. I agree. I love people. I think that recently somebody meant this negatively to me, but I actually took it positively. They say you are too nice when you explain things, even though I'm the one they come to go fix things, okay? That's why I'm talking about difficult conversations. They say, no, you're the Disney version of going and taking care of things. And I'm like, oh, okay, I'm cool with that. They meant it pejoratively, but it's all about perspective, right? So I volunteered actually to speak about difficult conversations as the person that people will come to over time because of my deep passion for people and trying to navigate difficult situations in a way that I can demonstrate mutual respect, something we all endeavor to do, but also to honor everybody as a valuable member of the team. And given that, I think that has probably cascaded and dominoed into some of these roles I have the privilege to be a leader in. And so I'm going to lead in with a story, not as good as your story, but as you can tell, I have an accent, okay? Everybody uses their different skills and traits differently. Mine works very nicely in the pediatric anesthesia realm when you have a very nervous family, nervous kids, and you walk in, you start talking, and they're like, oh, why does the doctor talk so weird, okay? So it's the beginning of the pandemic, and I go into a room, it's right when we started masking, and so now you have an accent and a mask muffling your voice, okay? So I go into this room, it's a 10-year-old little boy, and his family and he are bilingual that speak English and Spanish, and they only needed English. So I start going through my spiel, preparing him for anesthesia, and the boy looks at me, and he looks at his mom, and he looks at me, and he looks at his mom. He's like, do you understand anything that she's saying? And I said, cuando quieres, yo explicar todos en español. And then I just went through everything in Spanish. And at the end, he looks at me, deadpan, and he says, your accent sucks in 2 languages. I said, fortunately, anesthesia has no accent. So I will take excellent care of you, and you're going to feel great afterwards, even if you don't understand everything I have to say. But, you know, it's all about how you take it and how you segue, right? So in light of that, I have no disclosure or conflict of interest. And I want to talk about a couple of different ways difficult conversations may come forth, but sometimes we can be caught off guard by unanticipated discussions that can be uncomfortable. I want to share with you some considerations and strategies that have proven successful in navigating difficult conversations. Every one of you will have a story and something that you've learned and ways that you've changed your approach to something based on responses. And I hope that there may be a little pearl that comes out of this for you. So learning objectives, we're going to define what a difficult conversation is, discuss strategies to negotiate difficult conversations to a positive outcome, and explain a few examples on that. So the majority of us have not received education in negotiations, communication strategies, how to navigate difficult conversations beyond breaking bad news within our field and those that we intersect with on a daily basis. Often, we also have communication styles that, despite good intentions, result in the opposite response than intended, and then we're confounded by being a highly trained professional, yet still needing some optimization of these critical interpersonal skills to demonstrate the mutual respect and collaboration we consistently desire. So when we're looking at what is a difficult conversation, a very simple distilled definition is a conversation that's planned to discuss an uncomfortable topic or a negative experience, where the goal is to share different perspectives, build mutual understanding, but develop respect. It's not a zero-sum game. We're not trying to be the winner on the other end of this difficult conversation. And there are many different types that have been described, but I'll distill it down to these 3 different types. The what happened conversation, a feelings conversation where people are discussing how they feel about some event, and an identity conversation. Here are a few different books to consider reading. I love the one in the middle, Never Split the Difference. And while sometimes I may describe little kids as mini terrorists that we don't want to negotiate with, which we may describe a toddler as sometimes, not to negotiate with terrorists, there's actually a lot of really, really good tips in there about how to change the frame of reference that you use in order to not come across as if you're trying to win, but just have a discussion, gain information, and come to a mutual middle ground, or to come on the other end in negotiations for, let's say, compensation with the best benefit. The Art of Saying No is a good one. Crucial Conversations is great. You're going to find another book out there if you look it up saying Getting to Yes. I don't recommend that one because a lot of people feel fairly manipulated if you start out with little yes questions and eventually you try to get a big yes out of someone. And we're all very kind of type A, strong, educated personalities, and we don't really want anyone to make us feel like we're being manipulated. Some strategies to negotiate difficult conversations. I'm going to have to compare notes with Dr. Katari after this to see if he uses any of these strategies in his teaching at Stanford. But establishing rapport, looking at the framing questions for a no-based response, active listening, mirroring, labeling, communicating clearly, setting a deadline depending on the situation, and a lasting impression. One of the things that has resonated with me in preparing for this is the statement that was made to never take advice from a person you wouldn't trade places with. Criticism is a form of advice. So criticism being not a great behavior, nobody who's doing better than you will ever criticize you. So if you find yourself faced with someone criticizing you and you sit there and pause and reflect and say, well, I'm not sure if this is their insecurities coming out in my direction, don't take it to heart. I mean, sometimes that takes a minute, but that's the advice. So be open to learning, coachability, and then openness when you're having a discussion. Now let's talk about what we're not going to talk about, but I'm going to have a suggestion for you. So there are controversial conversations. This is the disclaimer. These are like areas that you avoid discussing, especially in the professional field: politics, religion, polarizing personal opinions from parenting to sleep training to circumcision to vaccination. You can lose somebody's attention because how strongly they feel about these different topics. Best to avoid them altogether. What about dissenting preferences in music in the OR? I've tried before to get certain songs played, and I've been told that I'm not allowed to play that dance music that they're not interested in. And please don't ever call country music bad in the Midwest. So navigating controversial topics has a few different approaches to it, but I'm going to give you a quick response that I use. You start with an open mind, you establish a common ground, use active listening, avoid personal attacks, etc. But here is my default answer. As a rule, I don't discuss topics that don't affect patient care or can negatively impact a relationship if a difference of opinion can occur, so I care too much about my professional and personal relationships to enter that arena. And then you don't even engage anymore. Segue. Now, anyone know what ChatGPT is? A couple people. I actually asked ChatGPT. It's an AI you can put in and ask a question and see what it gleans from skimming the internet for answers. I actually put in difficult conversation between an anesthesiologist and a surgeon. Okay? And this is the answer that AI has given us. And I want to point you to start with a positive tone. This almost sounds like how you tell, those that are women to smile and never sound negative, or you might be considered something that is a negative word I'm not allowed to say. So by starting with a positive turn when approaching a surgeon for a difficult conversation, it's essential to begin with a positive turn. This can help create a collaborative and open environment that encourages the surgeon to listen to your concerns. Start by acknowledging the surgeon's expertise and thanking them for their partnership in caring for the patient. Now, I'm not saying not to do this. I think there's a way to use this, but, it's interesting that I think that AI is a little biased towards the surgeons. Okay. So let's say you have a known impending difficult conversation. This is the better scenario because now you have a chance to prepare for it. The types of things you may be facing in our anesthesiology world are delivering bad news, disclosing a negative event, delaying or rescheduling a case, negotiation with non-medical leadership, not our favorite thing to do right now, but necessary, conflict resolution with a colleague. So what just in summary, that are really good ways to kind of plan your preparation is to identify the issue, choose the right time and place. This is an important part because one thing that I've been taught is don't enter the Colosseum where the gladiators go. Don't go into the position of power from the person you need to have a difficult conversation with. Find a neutral ground. Or if you're a little bit trying to lean in your own advantage, invite them to yours, okay? So choose the right time and place. Plan your approach. Practice what you're going to say ahead of time and even, practice that with some other people that can give you some constructive criticism. Listen actively. Listening. If there's one thing you're going to take away from what I'm going to describe to you, it's active listening. And then stay calm. Now, if you say to somebody, you need to calm down, that in and of itself is triggering, right? But if you know that in order to succeed in a difficult conversation and to navigate it successfully, that you adding emotions to that conversation will shut down their consideration of your position, then knowing that you need to if you're having those emotions arise, you need to go say and take a breather, regroup, come back, or schedule for a later date so that you can kind of stay in the composed manner so that you can achieve the outcome that you're seeking. So at first, establish rapport. So let's say you're going in and you're speaking with you're going to set a tone, use a calm voice. One of the things that Chris Voss says in his Never Split the Difference is use a late night FM DJ voice. Because when you're talking that way, no matter what you're saying, everybody just seems to feel calm when they're talking to you. Late night FM DJs put you to sleep, right? And we put everybody to sleep as well, actively. But use a calm voice, maintain professional demeanor, sit down, move to a quiet space if necessary. Then show true empathy. Try to understand the other person's perspective and emotions. Respond. Don't react. If you find yourself in a position where an event or something that requires a discussion has you in reactionary mode, that's when you need to give yourself a little happy time out. Maybe go get a little Red Bull from the cafe. Maybe that's not a chill strategy. A tea or something like that. So you want to establish rapport with the person that you're having the conversation with, because you're not walking in, downloading, and then expecting a positive response. You need to have a connection. So I'm going to describe a parental concern. I'm going to show you a nice picture there. So there was a child who had an anesthetic, kind of complex child, needed an EGD, intubated with a rapid sequence induction because of significant GERD issues and or GERD issues, and I do that with we have scented masks for kids. One's strawberry, one's bubblegum. I'm like strawberry, or anyway, segue. So this particular patient needed to have a rapid sequence induction because they had a history of aspiration pneumonitis with anesthesia. And then at the end of this EGD with biopsy, they were emerged to fully awake before removing the tube. Pretty standard of care. So the family then is discharged after phase 2, and the parent is driving home. She looks back and at her child in the rearview mirror. They're looking out the window and they see these little subconjunctival hemorrhages in the child's eyes and don't understand why that happened or whether something very negative happened and they need to be concerned and go to an ER. They made a call when they got home. We're in Nebraska, so we have kind of a large capturing area, so they were at a distance. They called and they were told by a nurse, oh, we checked with someone, that's totally normal, nothing to worry about. Then they said, I'd actually rather speak to an anesthesiologist so I can ask some questions. And then an anesthesiologist spoke with them and they said, yes, your child had a good outcome. They didn't aspirate. They woke all the way up. That's probably why that happened. They're not in danger. Mum then did not feel like she received the understanding and compassion and explanation that she needed to feel like something untoward wasn't possible for her child. So when the patient experience person calls the next day, how's your child doing? How did everything go? She explains the whole situation and they come to me and they say, all right, we need you to work your magic. This is what's going on. So I call the mother, I explain who I am, I explain what I understand happened, and I say, it sounds like that was really scary when you were driving home and you saw that. It must have been shocking. And she explains her feelings on it. I explain the situation very, very calmly and gently, and I say, I understand you had concerns. Now that you understand kind of where that comes from, do you have any further questions, something I can help you with? Would you like us to follow up anymore? She felt very reassured because I showed her the sympathy, the concern, the empathy, the compassion that she needed because she didn't get that in the other communications which felt rushed to her. So, establishing a rapport, I care about you, your child, I have children, I understand how that would feel, and that worked in that scenario. All right, let's get to know first. All right, it doesn't make sense because we like to hear yes, do we not? I want to hear yes for everything that's positive and no for everything negative, okay? Now, if you say, have you got a few minutes to talk? If somebody calls you on the phone, they're like, hello, is this Dr. Guller? Do you have any few minutes to talk? Who are you? It depends on who you are, right? Is now a bad time to talk? A colleague comes to you, an administrator or somebody that needs to ask a question. Is now a bad time? You can still wait. Maybe it's not a good time, but it's an easier pill to swallow. Oh, okay, it's probably not a bad time, or you give it an alternative. Is it a ridiculous idea? This seems like a crazy statement to use, but is it a ridiculous idea for us to consider getting some locums so that we can continue all of the anesthetizing locations being operational while we're in a shortage until X, Y, and Z months come and our new hires come in? Or if you say, would you be willing to invest in some, extra shift pay or some locums until that time rather than having us all work extra to make up the difference? Which one of them makes more sense? So if you look at this as not a zero-sum game, the best negotiations are those where both parties feel like they gain something and then you're refocusing away from an exercise of who's going to win this conversation or even airing of grievances. But getting them to say no or that's right. Do you disagree that we are needing to continue all of our locations being open right now because we still have a very high volume of patients coming in that need to be served? No, I don't disagree with that. Then are you against us coming up with a strategy that we don't have further attrition of our anesthesiologists as they make up the difference instead of finding a strategy where we can have extra shifts paid, etc.? Can anybody relate to these possible conversations? Okay. I actually do navigate these up at the administrative level, so it does actually work. It's received better. Let's go to the active listening. Okay. Active listening is when, rather than listening to hear, your listening demands that you listen with the intention of understanding. So what does that mean? Have you ever had a conversation, even with a close friend, where you're having a nice exchange, but when you're describing a story that means a lot to you, you can see their eyes slightly glazing over as they're considering a similar story that they're going to interject the moment that the breather comes in, and they're not quite listening, they're just kind of skimming everything that you're saying. They're not intending anything bad, but that's more of a passive listening situation. When you're talking to somebody and you're actively listening, okay, asking clarifying questions, repeating back to them what they're saying to you so they can fill in the gaps, pausing for long periods of time. I've learned this from the Cultural Map by Erin, I'm not going to remember her last name, The Culture Map. It was basically an author that helps in the business world understand the difference between cultures across the world and how we can come together by understanding the way that somebody wants to be communicated with, hierarchical structures, whether people prefer to have the punchline at the beginning and then describe how you got to that punchline afterwards. That's actually the American preference versus the German preference, which is tell me all of your thoughts and processes, then tell me with the conclusion you came up with, which depending on how you deliver it depends on what's received. Where does this come from? When you are looking at active listening and you're thinking of cultural expectations, being able to repeat back to somebody what they're saying and then wait significant amounts of time. In the American culture especially, people like to fill silence with words, okay? Do we all agree that that's the case? Uncomfortable silence, I think that term was coined here. It's understandable because there's an air about it that maybe something bad is going to be thought about, or maybe they're nervous, etc. So that uncomfortable silence actually is an opportunity. So as you're having a discussion and you ask a question and then you actively listen and then you wait, they will start filling it with information that sometimes you won't get all of if you keep asking question after question and interrupting them with further clarifying questions. Active listening requires you to pause and allow silence to occur. So you make a statement and then you use the silence as a powerful negotiation tool, allowing the other party to show you what they're thinking, and then you can respond rather than open a negotiation maybe with an offer less than what you would be willing to provide. This is a negotiation tactic. Okay, what are you willing to offer? If you open with, well, I'm willing to accept $300,000 for full time, then they'll be like, oh, nice. I was willing to pay $4, but I'm not going to offer that now. So open it up for them to be able to fill it in. We're going to talk about mirroring, labeling, and calibrated questions in light of active listening. All right, mirroring. Has anyone heard of mirroring before? Okay, excellent. You're listening to them, and then you use keywords in your discussion to repeat back to them as a question or a statement to make sure they know that you are actively listening. Sounds like you're concerned about a delay in starting the case. You don't expect any blood loss as a reason for not wanting me to do an arterial line. You were concerned about the blood in the white part of the eye. So mirroring, use those keywords, and then they will know that you're listening. And then by using those exact same words, you're segueing into a further part of the conversation. Okay, I'm concerned that tonight there's going to be a blizzard in Omaha. You're concerned about the blizzard? Yes, I'm worried that the people that live at a farther distance are going to have trouble getting into the hospital, even though we know that nobody cancels their cases during the middle of a blizzard. This is legitimate. Even a 5-minute ear tube, you're like, logistically, I would expect 50% of my schedule to clear. No, not one person will cancel. They will truck their little way through the snow, be up to their window, and they're still coming. So they will even hire rent hotels near the hospital for nurses to stay in so that they would be able to walk across the road if the conditions got bad enough. So you're concerned about that. Well, what do you propose about those people that live at a distance? Well, maybe we should rearrange the schedule so those that are closer, that have less precarious of a trip, maybe would be the ones that would be the backup in case we have conditions that don't permit them to come, so that we can still serve all those patients that will turn up. Okay, well that sounds like, how do you want to go about that? So you're allowing that person to solve the problem they're concerned about by mirroring back to them the things that they're concerned about and discussing. Labeling. Okay, this goes partner with mirroring. Okay, So somebody says, I don't know why they're not appreciating us by paying us more when inflation is 8%. Anyone felt that way? Okay. It seems like you feel like you're anxious about being able to make ends meet or pay your bills, or that the compensation is a big concern for you. It sounds like, it looks like, it feels like. So same thing can happen with surgeons. I don't think that we need an arterial line for this 2-year-old splenectomy. I've had that happen. So I'm like, it sounds like you're concerned about having an art line because of maybe how much time it may take. Yes, I don't like waiting that amount of time. I think we need to make sure we move forward. Well, it looks like if we found a way to be able to put that arterial line in while you're prepping and draping, and thereby not delaying the case any further, as long as you give me an arm out the side, we should be able to mutually achieve the same goal, which is patient safety. If you're thinking, I don't want you to be upset about this, then label it. Seems like you're upset about this. Pause and let them fill in the blanks. Use the compassion. I'm going to switch the empathy I've got written here. And then labeling gives verbal acknowledgement of those feelings, and then acknowledge and take stock of any communication styles and breakdown. The reason that I wrote that in my notes is recently somebody in the midst of frustration said, you don't speak up loud and clear and with the same fervor as everybody else in the same style. And I said, everybody's communication styles are different. There's pros and cons to everyone's. I value yours as somebody who's very direct, and others may value mine as being somebody who navigates things with an air of finesse that can be interpreted as if I'm complicit, complacent, and not actually caring, but I do a lot of things behind the scenes. I don't need to tell you what I'm doing. When you know me, you know that I'm doing the things. And they were frustrated that I wouldn't kind of convert. But it's the same thing. You can't expect one person to communicate the same as the other person, but you can use tools to help you. What and how questions rather than why. Why elicits an emotional response. Why? This is unfair. Why do I have to do this? How am I supposed to do this? How are we supposed to keep all of these locations open? What are we supposed to do if this child loses more blood than you're anticipating? How are we going to take care of that if the child is 2 years old and you've tucked them so far underneath the drape I can't get to their arm to put in the arterial line? Then in the communicating clearly, you use calibrated questions. What makes you ask that? How would I go about that? We just described that. What is the primary outcome that you're seeking? Now, another facet to that is don't waste time kind of going through, well, I've been able to do this, this, and that before. Focus straight in on how you can use the skills and the resources you have to help solve a problem. Set a deadline. They've been able to prove in negotiations, let's say you're negotiating a contract, if you set a deadline, you get a better outcome. Well, I'm going to need an answer in the next 2 weeks on this specific date. I'll be looking for an answer before then, and then follow up a couple days before. If you leave it open-ended, is anybody racing to give you something that is going to make them uncomfortable? Probably not. So set a deadline. Email a summary. If you don't go on record, it didn't happen. Now, be careful with that. Some things you're going to kind of keep to yourself, but email a summary, ask if any information gaps exist, and that way you're going on record for accountability for those types of things that you need to kind of carefully navigate. Lasting impression. Right. I love to go in. We were taught this big class on heart, head, heart. They were saying, start in with a positive statement, then deliver your constructive criticism, then end with a positive statement. That is a heart, head, heart sandwich, right? So some people don't feel really comfortable with that strategy, but I can tell you that leaning in and building a rapport is a good way to kind of start with a connection. But rather than lead in with a positive note, leave on a positive note, because the last impression is a lasting impression. because the last thing they'll remember is what you were talking about as you went out the door. I know this has been a difficult conversation. You know we work very well together, and our common goal is the safety of the patient. And so as we continue to work towards that, I'm really glad that we can collaborate together, and I appreciate you. It goes a long way. Also, know when it's time to regroup at a later time as you consider information shared. Now, not walking away, because if you walk away with the intent of coming back if conditions are more favorable, that's kind of disingenuous. You really just want to allow time for consideration. All right, so we've talked a little bit about anesthesiologist and surgeon discussion. I'm going to give you a quick example. Okay, it's probably about 5 years ago, and I am going to have the privilege to take care of a 1-day-old who has jejunal atresia. So I go up to the NICU, and I go to start talking with the father who's present. The mother is still at the hospital she delivered at. And I say to the dad, who just happens to be Australian and thinks that his Melbourne was better than Adelaide, where I'm from. Anyway, so as we're discussing, I said, well, I don't want to go over the anesthesia plan about your child until mum's on the phone, because I want to make sure we discuss it together. So as he calls mum, he's looking out the doorway, and at the far end of the hall, about where our amazing AV team is at, he can see the surgeon coming. And as he gets her on the phone, he goes, honey, the doctor is on his way. And I go, the other doctor? And the surgeon arrives in the room, not surgeon, he's really a surgeon, so I didn't need bunny ears for that, but he arrives in the room hearing me say that and says, actually, you know how sometimes people's verbal slips are actually truth coming out and manifested? He says, we don't really consider anesthesiologist doctors, but more like physician assistants, because, you know, we bring the cases and all this stuff. And I look at him and I'm like, ooh, he's lucky I'm not somebody else right now. I said, last time I checked, we both went to medical school and residency and fellowship and la la la. And so then he looks at me, realizes his mistake. He takes over, goes through everything. And in the conversation, he goes, and then you'll talk to your anesthesia doctor, who's an excellent doctor, and she's going to take care of you because she's a great doctor and all this stuff. But I couldn't leave it there, but I'm not going to engage in this topic when I need to pay attention to that patient for this case, right? I actually sat on that for a couple of months because I'm like, I'm not going to go to his office in his personal space and confront him about this inappropriate and unprofessional behavior. So a fortuitous moment occurred when we were standing in front of the board together by ourselves, and a partner who worked with me on the acute pain service somehow didn't mesh with the team that well, with the surgical team. And this surgeon looks at me and says, you know, Dr. Guller, we really love the way that you collaborate with us surgeons. You always consider our input, and we just really love the way that you communicate and your style. And I said, well, as long as you never call me a physician assistant in front of a patient or their family ever again, I think we're square. So, and then since then, every time he sees me, hello, Dr. Guller. He will never call me by my first name. We're in a good place now, but, you know, I had to make sure I didn't leave it there, but at the same time, I didn't want to have a reaction other than what a little bit correction that I did at the time. Let's talk. We've actually had good examples on an anesthesiologist and the patient caregiver relationship. And I loved the one that Dr. Lilach Rothschild gave. So the other one is the anesthesiologist and the administrator. I actually think this is a very key topic, and I'll just give you a brief overview. You can read over it when you download the presentation, but prepare when you're going to go and speak and interface with an administrator in advocacy for operations and patient care, resources, etc. Discuss ahead of time with a knowledgeable leader or colleague to gather information. Always stay professional and neutral. I witnessed in all of these different things we've had to navigate with the shortages. I mean, in pediatrics, we've had shortages of liquid Tylenol, liquid amoxicillin and Augmentin and ibuprofen, and staffing shortages continue to be throughout the country. And in big operations meetings on how to prevent diversion of patients to elsewhere outside of the city, the hospitalist group did a really good job of sitting there and just asking. And how would you like us to go about that? And we used to have this resource, and that was helpful back then. Is that a possibility? And those types of things. And at the end, I sat there and I said, there was so many things you could have been reacted to in defense of your own shortages and the own burdens that you bear, but you didn't. And I'm impressed by you. And this, one of the hospitalists said, what I've noted is the moment that emotions enter the discussion, then the administrators shut off and they hear nothing that you say after that. So I've found that I only get things done when I stay emotion-free and just objective. Here, I'm going to leave that one for you to read when you navigate between colleagues. I just think it's a very heated time right now, so there's a lot of different things that you can navigate. But our key takeaways and things I want you to attempt to put into practice. Practice verbalizing observations. It looks like you've been running around like crazy today. Do you need any help? How are you feeling? Start with a no question. Actively listen. Repeat back with mirroring. Validate feelings. It seems like you have a reason for saying that. I am so frustrated with what's going on. It seems like you have a reason for saying that. And then listen. Ask about mutual goals. Show gratitude and authentic humility for the last impression. And like I said, remove emotions from the discussion. So here's the references and some specific things to anesthesiology that we navigate. Okay, and I think the little extra time you started on gave me a couple more minutes. So thank you very much, everybody. We'll have questions at the end.
Thank you so much, Dr. Goller. I will now turn it over to Dr. Ladowski to give his lecture on cannabinoids during the perioperative period. He is a senior consultant in the Department of Anesthesiology and Perioperative Care at the Mayo Clinic and senior fellow at the Leonardo Davis Institute for Healthcare Economics. His research interests focus on regulating DNA expression in survivors after critical care illnesses, healthcare operations, medical decision-making processes, and healthcare innovation, artificial intelligence, nanotechnology, etc. He founded a startup, QBIMM Diagnostics, a company oriented at diagnosing immune disorders such as nanotechnology. He is also the president of the Society for Healthcare Innovation. Please give him a warm welcome.
Well, thank you very much. I'm actually a normal person. He read way too much. There's a couple of things. I'm going to talk about the cannabinoids. I have to say that talking this on the wellness session, I was like thinking, should I bring the samples? Then I realized we have a presidential actual party after that, so I don't need to. All right, so let's talk about the cannabinoids. So this is my disclaimers. Nothing of that will sort of impact what I'm talking about. This is our objective. So we're going to talk about the very contemptuous subject, cannabinoids. And what I'm trying to actually instill in you during this talk is that we know actually very little about it. There's a lot of emotions about the problem, but the data are actually extremely sparse. So what are cannabinoids? Cannabinoids is everything that you can find. This is a certain class of the compounds you can find in the cannabinoid plant. That means is that first of all, define them is difficult, and we're going to go through that problem. What's the history of the cannabinoids? So cannabinoids started 12,000 years ago. Discover the cannabinoids in the current world is nothing new. 12,000 years ago, we knew that they exist. They were used in the Neolith. Greeks reported of them, Romans, Chinese, Middle East, and then actually Spain came to Spanish conquistador went to the Chile and brought the cannabinoids to the Europe. Now the important part that the first synthetic cannabinoid or THC, which is was actually synthesized in 1940. THC was actually synthesized in 1964, so understanding the chemistry of this drug is really recent history, which goes a little bit into the problem related to talking about these drugs. So cannabinoids actually were legal in the United States. They were actually taxated as of 1937. So you could buy legally cannabinoids. Unfortunately or fortunately, 40s, 50s, and 60s, we start having politics mixed into the drugs. And we start talking at that time that cannabinoids or the pot is the way how the people get hooked up to the drugs. That's how the bad rep to the cannabinoids started. Then in 1969, cannabinoids are on the Schedule 1. That means they're not being, they cannot be used outside the research realm. This is equivalent classification with the heroin, which cannot be used, and is actually one of the highest offense in the DEA. In 1972, we have a first attempt to legalize marijuana and cannabinoids. First state legislation happened in California in 1996. Now, the current situation about the cannabinoids, legal one, and I'm not a legal expert, is extremely confusing because what is happening, several states, as you can listen from the news, are legalizing cannabinoids. However, on the federal level, they're not legal. That's also what it means that DEA or FBI issues several guidances, but they're just guidances. They're not law on the land. That means is that if you're talking to the patient about the cannabinoids, you put yourself in the very interesting legal jeopardy. Do I prescribe them? Do I recommend them? Which one? Especially the one which we use in the more recreational way, not the one from the category of the drug. So pay attention when you have this discussion because it depends on the state. Now, type of the cannabinoids. There are two different classifications of the cannabinoids. One are the synthetic, another one organic. Synthetics are the one that we make in the lab, and that class is actually extremely potent. They're designer drug, and you will hear a lot of them in the context of the war on drugs. The one that you hear most of the time are the one made from the plant, and cannabinoid plant, when it's being manufactured, can be manufactured several ways. The most popular thing is marijuana. That's the dry leaves from the plant. If you compress those leaves, then you get a hashish, which is much more popular in the Arab countries. If you squeeze the oil out of that, you get a hashish oil. And there's something called the hemp. Hemp is actually leaves and stalks and all the parts of the cannabinoids with the one very important caveat. It has to have a less than 0.3% of THC. THC is the psychoactive substance, and DEA will classify everything according to contents of that substance. This substance makes people paranoid. That substance makes the people having quote-unquote high. That's what a lot of drug addict is being sought after. But it's not the only cannabinoid that you have in all this group. So this is another classification of the cannabinoids. And what you have over here is natural occurring and synthetic. And in the middle, you have another group, endocannabinoids. So our body makes their own cannabinoids, and they actually have functional properties. And we unfortunately don't know very well what is their biological function because that field is extremely under-researched. But there are naturally endogenous cannabinoids. In the terms of the natural occurring cannabinoids, you will see a lot of different abbreviations. The bottom line is that what really counts is the amount of the THC in those substances. That what makes the substance legal or illegal in a lot of ways. Then you have synthetic cannabinoids. So around 1980s, drug cartel, or actually it starts from the pharma, start looking for the natural agonist for the cannabinoids. And now you can actually design them the same way you design the fentanyl to bind to certain receptor. You have medical substances which are synthetic ligands to the cannabinoids. Those are extremely potent, they're extremely harmful. We don't really know what they do, but what is important is that synthetic cannabinoids are very frequently added to the illicit substances that our patients can purchase. Now, are there any cannabinoids which are approved? Everybody heard about dronabinol. It's a medication for the appetite, it's a medication for the muscle wasting. It is one of the oldest medications which based on the cannabinoids and it's actually approved. There's a couple other medications, Sativex, Epidiolex, Casemat. All of those are from focus either on the epilepsy medication or they focus around the appetite stimulation. So those are approved. Those are also very expensive. And if you think about the population which this medication will be given, it's narrow. Now, how the cannabinoids works? So the major mechanism for the CB1 and CB2 receptor, cannabinoid receptor number 1, cannabinoid receptor number 2. Okay, both receptors, cannabinoid receptor number 1 is mostly in the brain, number 2 is mostly in the periphery, but those are not only receptors which play a role in the cannabinoid function. However, we know very, very little about the other receptors that cannabinoid binds to. The reason is that the research about the cannabinoids was impacted for 50 years because of the legal battle above marijuana. So there's really not that much studies that you can actually go and rely. What is happening right now with all the impurities that you see in the cannabinoids, a lot of studies is done on not only on the THC, but THC with something. And we're going to talk about it when we're going to talk about evaluation of the patients who comes and tells you, I'm smoking pot, how to approach this. So in terms of the physiological action, 2 major receptors, CB1, CB2, in the central nervous system. CB1 is pretty much a receptor which will hyperpolarize the neurons. That receptor is responsible for one of the application of the cannabinoids, which is anti-seizure medication. You will have some of the patients who will come and they will tell you the story that I tried 20 different anti-seizure medication. The second I'm on the cannabinoid, I don't have a seizure. That's how that's the mechanism responsible for that. There is some relation of the cannabinoids to the memory formation. There is some pain effects by the cannabinoids, and we're going to talk about it a little bit more. There is some antiemetic mechanism, but there's also a lot of psychological effect or the cognitive effect that we just learn how to study. This endogenous endocannabinoid system, we believe that this system is involved in the neurodegeneration, neuroprotection. We just learn how to investigate the system. That's one of the potential that pharmaceutical companies see in the terms of developing new drugs. In the terms of the other system, cardiac system, so we don't really know there is a direct effect of the cannabinoids on the heart, blood vessels, and other organs related to the cardiovascular system. There's a lot of indirect effects. What most of the research shows, and this is a poor research, you have a lowering blood pressure and you increase your heart rate. How this works, we're actually not sure. And I'm going to talk about this when we talk more about the plan. In the terms of the physical function of the pulmonary system, so you can split this in two buckets. One, what happened for the receptor function. So CB1, CB2 receptor, they're present in the epithelia, they're present in the immune system. They have potentially some effects on the pulmonary system. We don't know how. However, when our patient inhale pot, they also inhale smoke. This is not different from smoking, having inhalational injury. This is not different from smoking cigarette. So you will have a bronchospasm, you will have a non-specific activation of the inflammation, you may have some more phlegm. All of these things come together with the territory, and dissect those effects from the pure effect of the cannabinoids is difficult. Also depends, and this is, I hope I didn't make this too small, but depends who study what. You get really opposite results. Some people said it caused the bronchodilation. Some people say it caused the bronchospasm. There's a paper which shows that if you use the cannabinoids, you use the less pressor. There's a paper says that you use the more pressors. Usually, from my review of the literature, it very depends which journal you publish. And that's kind of makes all of this even more confusing. There are other effects of the cannabinoids. It's immunomodulators. We do not know what exactly, whether it's immunosuppression, is it immunoactivation, is immunomodulation. There's some effect on the liver. We know that it causes the fibrosis and steatosis. Whether that has any translation into physiology remains to be seen. There are some changes in the metabolism. There is effect on the thyroid and other hormones. And the cannabinoids can actually induce the hypothermia. Again, we're not sure how this mechanism is used. Now, how often you're going to see the people who have who actually taken cannabinoids? So all of us go to the patients. Again, I'm not sure how you create your pre-op plan, but I go to the patient and ask, do you smoke, drink, and do drugs? Now I'm asking, do you use cannabinoids? And I'm asking that because I would like to know, because it may affect my plan. Now, statistically, most of the Americans never use the pot. This is the data for 2016. 150 million never use it. 78 million used once and they stop it. But there's some remaining number of the people. They use the pot and they probably use it within the last year. So it's not an eligible amount of time, and there's around 8 to 10 million people who use it every single day. So probability that you're going to meet somebody who uses the pot is relatively high. Okay, and this use of cannabinoids is the use for, let me put it this way, non-medical reasons. This is not the drugs related. That also means that quite often you may deal with another addiction together, or with those impurities that sometimes are added to the cannabinoids to augment their effects. Now, this is extremely difficult to quantify. Use varies by place. So this is how much metric tons, for example, New York City uses. And it's literally 80 tons, right? I was surprised when I saw this number. I thought it's a kilograms, but I was just very naive. Okay, you know, there's Moscow, Toronto, Chicago. There's even Chicago. Like Chicago doesn't even come close. It looks like statistical error on this, right? Then if you look at the actual different states, this is the data from 2018, it kind of is more the same, between 40 to 60% of the adult population between 80 and 66 use the marijuana at least once in their lifetime. So again, it's not something that will not happen when you approach the patients. It's probably comparable to how often people use the alcohol these days. So this is how the use of the cannabis looks across the world. So when I actually was preparing this, I was a little bit surprised that, we're not that far from Australia, Egypt, there's a couple other places like Bangladesh. It was kind of nice curiosity, but definitely United States, one of the highest user per capita of the cannabinoids. Okay, why do people use it, right? So, I don't ask the patient why use the cannabinoids, but it's kind of good to know. And, one of my first contact with the cannabinoids and the prescription was I flew to the Las Vegas, I get out of the airport, and there's a big banner that, yes, I can give you a marijuana card. It was like 2015. I was like, oh, that's kind of interesting. Why do I need a marijuana card? And now I discovered, like, for headache and other things, I walked to the gentleman and he told me it costs you $50 and I give you the card. So it was like, where do I put it? Medical use, just for fun, detour? I'm like, I don't know. Okay, but this is more or less how, why the people use it. Again, it's not my business when I ask the patient how they use it, but that just kind of gives you an idea. Now, when patient tells me I'm using the marijuana, the next thing you're going to ask, like, how much, right? How do I quantify? And that's when the problem happens. That's also what happened is somebody maybe overzealous ran the UTOX screen on the patients, and now you're running even more problem. So marijuana metabolite, how you can be testing the urine, blood, and saliva. Okay, and what you test is the THC presence. The problem is that the THC is relatively slowly metabolized, and that means that if somebody uses once, the test will be potentially positive for 2 to 3 days. If somebody uses more than twice a week, the test will be positive for 2 weeks. If somebody uses 2 or 3 smokes per day, it may take months to clear. Okay, so that doesn't tell me exactly whether patient use it or not, because there's a problem of the intake and the half-life. The second thing, I don't know how much, because all those are the semi-quantitative tests, and it's hard to say that 15 picogram of THC is twice worse than 7.5. So I'm not sure what to do with those. The second thing is there's some false positive. Okay, I think the recent self-positive was that US Navy advised the sailors not to eat the poppy seed because it may apparently cause the positive test. I didn't research that, but that's what I found recently in journals. And this test will not detect synthetic opioids. So that means is that anything which is constructed in the lab, which our patients might ingest with whatever they bought on the street, will not be picked up by this test. All right. Let's talk about the anesthesia, okay, so because this is kind of the most funny part. So if you think about the anesthesia effect, I decide the way we sort of will go about it. We define the effects by the systems, and then we talk about how this impact plan. So first of all, if you're talking about central nervous system, if our patients come to us with some active, past, present, or errant intake of the cannabinoids, very rarely they will be calm. Actually, what the cannabinoids induce is quite often they come to us in the some state of the withdrawal, so you have anxiety, you will have a nervousness. Patients will probably, not only there's a withdrawal, patients don't want to tell us. So that's not the best platform to start anesthesia, even with the best compassionate skills. There's some patients who come with the acute intoxication. The interesting thing, if you look at the symptoms of the intoxication, in my view, they're unrecognizable from the serotonin syndrome. So you will not even know whether the patient is or is not in the acute intoxication. They will look just sick. The second thing, the patient might come with the exactly opposite way in the withdrawal syndrome. Okay. That's again, all those things related to the imbalance that the cannabinoids introduce into the brain on top of using other substances. And if the patient took the synthetic cannabinoids, it gets even more complicated. Now, there's more and more data that cannabinoids actually may affect also risk stroke. So if you look and you start researching this data, it actually go back to 90s. That there's a more and more singular publication that there's increased risk of the ischemic stroke. And because of the hypertensive sequela, some of the stroke may convert into the hemorrhagic stroke. Now, should that wait into our anesthesia plan? I just don't know. But this data keep appearing, and we can talk about what's the reason for that. The next thing is effect on the anesthesia, on the cardiovascular system. So there is a very significant body of evidence that perioperative use of the cannabinoids is linked to the increased risk of the acute coronary syndrome. And this is actually one of the best data that exists out there. The paper which is here is from 2001. It's published in the Cardiology. It's the large study. And there are several papers afterwards. This is, I think, the only substantial, significant, and well-documented effect of the cannabinoids on the anesthesia risk, which, again, this data appear from 80s over and over and over. The data are consistent, even in the journals which have cannabinoids in the title. So that's something that I would take into account. And the reason why you have increased risk of the ACAs are kind of unclear. One reason what we believe is that there is some kind of sympathetic discharge. The second thing, we believe that cannabinoids may increase the viscosity of the blood. They may also cause spontaneous rupture of the atherosclerotic plaque. They may cause dissection. Which of these mechanisms is the prevalent one? To be decided. But there is some increase of the cardiovascular events if somebody is taking cannabinoids. Would that warrant cancellation of the surgery? Well, they will take months to clear in the active user. So I don't know how to factor this into my anesthesia plan decision to qualify or disqualify to anesthesia. There's some articles demonstrating that cannabinoids may induce vasodilation. And the paper which showed the graphs over here is a relatively old paper, and that paper says that if somebody is cannabinoids, I have to use less pressor to reach my mean arterial pressure of 65. Authors on this paper did not comment whether that will impact someone who has aortic stenosis, for example, with the critical value. But this is the only paper I was able to find in my search for this talk and article about vasodilatory hypotensive effects of the cannabinoids. Next thing is, so let's go back to the anesthesia plan. So first of all, you approach the patient. Does the patient consume or not? It's actually an interesting question because will that change my management, right? And to be honest with you, I used to ask and now I don't ask because it's not going to change my management in the dramatic way. It's going to change the way I weight certain risk, but it's not going to make my decision that I'm going to use the different pressor, different drugs, different premedication. So I used to ask, and now I stop. Some of my colleagues disagree with that, but that's a different story. Some people ask, do you use the medication for this or that? Unless the patient has we have either EPIC or alternative. It says the list of the medication. You can go through the list. You can figure it out. If the patient takes dronabinol, or he just smokes the pot. I don't think so. We should ask the patient about that. The question how much and how long helps occasionally to figure it out whether your patient will have some kind of emergency reaction in the PACU, or if there's some kind of complication. But again, do you want to engage with this discussion? Again, will that change your plan? And there's a kind of interesting body of evidence, which I don't know how to translate, that actually cannabinoids slow down the gastric emptying. Whether that should change our NPO guidelines, $1 million question. I always want to make a study when I ask my patient, when was the last time you had anything to eat? And then I actually scan the stomach. And I'm pretty sure I find a 30% difference, whatever is in the stomach when they told me about fasting. So this, again, doesn't really impact that much of my practice. Now, there's a lot of, well, not a lot, 3 articles talking that if you take cannabinoids, you need a more propofol. Okay, and these articles come from the different sort of sources. There's one article from European group which says it's exactly opposite. The one which is now much more common is published by the group from Colorado, which is based on the retrospective chart review. The problem is that if you ask, how do you know that the patient takes cannabinoids, is dependence coded in the EPIC? Well, a lot of people probably won't say. So there's not that any of this paper tests the patients for the presence of the cannabinoids to actually get a confirmatory test and gauge it. So is that possible that this patient takes another substances which render more, less sensitive to the anesthesia? Possible. I would not associate these results purely to the cannabinoids. If you do induction, there's a risk of the irritability, the same like with the smokers. I believe there's nothing special about the cannabinoids. It's an inhalational exposure. And there's this risk of the aspiration that we talk about. Now, when you're in the maintenance, apart from the article talking about the propofol, tachycardia may occur, and this is actually consistent again through the literature. This may be one of the reasons why the people get more ACS, because you could imagine if someone has a critical LAD stenosis, you induce them, they are under anesthesia, they have a low blood pressure, they have the tachycardic, they will have a probably oxygen demand mismatch, then the risk of the ACS is higher. But is that the effect of the cannabinoids? No, it's the effect of the state that the patient is in. Increased dose of dancing or not is to be decided. And one of the reasons is that, again, our patients quite often take another substances, and how you dissect the cannabinoids effect from that is difficult. The second thing is cannabinoid is not equal to each other. Pot that you buy in the Colorado is different from Seattle because the difference in the THC, in the amount of the THC, will vary. Just because patient says, I smoke one, whatever, joint, this may be a very different potency. It depends how that was made, by whom, and how it was processed post. So again, I think we have to sort of ask ourselves, what is the pure effect of the cannabinoids? What is the effect of the related substances? Emergence, psychosis, emergence reaction, bronchospasm. And now, very interesting thing is some people claim that the patients who take cannabinoids have a higher risk of the nausea vomiting. That's interesting because industry studies agonists to prevent nausea vomiting using cannabinoids agonists. So I cannot reconcile those two, but that's pretty much it. We're almost done with our talk. So on the post-op, just to kind of throw a couple other things is, when you discharge the patient, should you worry about this increased risk of the acute coronary syndrome? There is some literature about the suicidal ideation, which now is sort of emerging. Should we worry about it if we discharge the patients? Question the possibility of nausea and vomiting and pain management. Now, pain management is interesting, and I couldn't reconcile this for a long period of time because we use cannabinoids to treat the chronic pain syndrome. But if you look at the literature in anesthesia, if you take cannabinoids, there's pretty convincing amount of data that you require more narcotics to achieve the same goal. Well, there's acute pain and the chronic pain, and they're dramatically different. So I think people, the synthesis of this data is that endogenous cannabinoids probably help with the chronic pain syndromes, CDS, whatever we classify them. However, that's not what our patients deal with when they have appendectomy. They deal with the acute pain, and over there, cannabis may induce certain resistance. So when you think about, the way I reconcile, it's a difference between the nature of the pain, chronic or chronic versus acute. Cannabis will have a different effects. There's also comorbidities. Some of our patients take different medication. And then the cannabinoids seems to have some anti-inflammatory effects. How much of this is responsible for pain management during in the postoperative period? I don't know, but I would probably put my bet on the fact that if the patient takes cannabinoids, you will end up using more narcotics because they will build some resistance, either for the cannabinoids or the other drug use. Now, this is how I approach my anesthesia plan. So for me, the question is, okay, do I need to take an intake assessment? Like if it's really critical. If the patient tells me up front, I smoke pot every day, well, that sort of gives me, kind of stratify this patient to the higher risk class. I look, I ask whether they use any other substances, because that helps again. If the patients take cocaine, if the patients take the fentanyl, that will change what we do. Okay, and I'm not saying that the cannabinoids are always related to that other drug abuse, but they related somehow. And I don't think so there's a harm in asking. If the patient is extremely anxious, is in the withdrawal, is the patient competent to actually give me consent? Like, it's hard to ask somebody who is in the withdrawal, would you like to have anesthesia? This is the least of the risk. And the patient is like, not able to even focus on my face for 5 seconds, right? So that probably doesn't meet the criteria of the legally sound consent. Question of the pulmonary function. This is the same question I ask everybody who smokes. How long do you smoke? If it's more than 20 years, will I deal with some kind of emphysema, bronchospasm related issue? Intraoperative management, I do not do anything special. Again, I may be more prone to use, some people say you have to use more anesthesia, but our titration of anesthesia is extremely imperfect. If the patient is asleep, whatever that means he's asleep. If you use the BIS, maybe you're more precise. We can talk whether BIS is the best way of doing that, but pretty much patients lays on the table, doesn't move, is good. Whether you use 180, 200, 160 of propofol, we both know that this is a numbers and may not have a relation to the anesthesia. Would I consider, would I give the patients more opioid? Potentially, yes. But again, nothing to the dramatic levels. There's also a paper about the BIS interference with the cannabinoids. But in that particular paper, the patient was not paralyzed, so I don't know whether it was eyes movement which affect the reading of the BIS. But that's like one paper I was able to find. And the postoperative management. So that's again, pain management comes in the action. I probably expect that my patient may require more pain medication. If they have emergency reaction, I will not be surprised, and I also will do nothing different that I would do otherwise to manage their emergence. And then I a little bit worry about the long-term risk. Now, what's the future of the cannabinoids? So this is last 3 slides. So they probably will be useful drug in the inflammation, seizure, and appetite modification. That's when the most of the current portfolio of the pharmaceutical company is in terms of the development. In 10 or 50 years, if the cannabinoids will be proven to be effective, you see them more in the neuroprotection and neurodegeneration. But that's a future. Now, more research has to be done. There is no really good research about the cannabinoids. The subject is very emotional, very political, and we don't want to talk about it. Studying that comes on with the third rail in research. So if you want to touch it, sure, but your career may be permanently affected. This is not really inducive. It is not inducive to do research on this. Bad. So we have to investigate whether there is effect on the bronchospasm. Would be good to know what is the long-term effect of the cannabinoids on the cognition, especially that we give our patients anesthesia, and there's this ongoing discussion anesthesia about that. Is the increased risk of the stroke? Is this increased risk of the DVT? Again, excellent ideas. If there's a junior faculty who wants to solve this problem, I think you can build a career on that. Okay, and finally, the ugly. We still don't know, but I think this is very well established that there is increased evidence for acute coronary syndromes when you take cannabinoids. Postoperative pain management will be complicated. I did a slide some time ago, so the third one I would strike about the intraoperative increase in the anesthetic demand. There's a problem what to do with the synthetic cannabinoids. This problem is becoming bigger and bigger. I used to practice in Philadelphia. It's not absolutely small problem in Philadelphia. You have people coming on the synthetic drugs, and they are very difficult to anesthetize on many levels. Another question: what is the long-term effect of the cannabinoids? So thank you very much, and I will take a question. Thank you.
Thank you so much. We will now begin the panel discussion and Q&A portion. So if anybody has any questions, if you could step up to the mic and.
I just took my pulse, and I think I'm well. So thank you guys for doing that. 3 excellent presentations. At the hospital I'm at, I work with the administration a lot. There's a lot of buzzwords: just culture, high reliability, psychological safety. But what I was really pleased to hear a discussion about today was empathy. I think as anesthesiologists, it's probably our most sought after trait. And I do have a question about empathy because, you know, I mean, you guys know we have 4 to 6 minutes to win over the trust of a patient. It's literally putting their life in our hands. And I think if we're not showing empathy in that scenario, we're probably in the wrong field. So I guess my question is, like leadership, do you think some people are born with it? Is it innate? Can it be learned? How do we do a better job teaching our colleagues?
Okay, so great question, thank you. And I don't think it's innate, although I do think there is an innate pro-social motivation that we have as infants. Even you hear a baby crying, and the baby next door also starts to cry. That is true. That is a studied phenomenon, and that's a pro-social motivation and connection. So can you say that it's innate? I'm not quite sure, but it's definitely a skill that can be built. And I don't know, I work a lot with medical students, and I head up some of their wellness curriculum, and I have 48 advisees, and I often say that I'm trying to change medicine one student at a time, because I try to impart on them that these are the things that really matter at the end of the day. You're going to learn all the information, but really if you can just connect with your patients in a way that is meaningful, that offers them something beyond just the medical care, I think that's where the money's at. And so I would love to see this kind of work and this kind of training in all of medical education. I think that's a hard sell because that takes time, that takes energy, and that takes initiative, and all things that are very, very difficult to come by these days, right? So I think it's critically important, but I think, again, it's like, you know, turning the big ship in the ocean. It's barely gonna pivot, but all these steps hopefully will create some momentum and create some change over time, is my hope.
I personally think that some EQ is built in and cultivated over time. You can feel the energizers. You go in the room, you're like, I know I'm going to walk out positive from an interaction with that person. And then you know the de-energizers that you're like, oh, they're going to suck some energy out of me. I have to tread cautiously. But I think that, you know, as long as there's a kernel of emotional intelligence, that you can cultivate that further in the compassion direction. Right.
Thank you. Go ahead.
I just wanted to mention a few months ago, ASMR came out new guidelines regarding the periodical questions about marijuana, and their guidelines had mentioned everybody should ask about marijuana use because of increased pain and nausea after surgery. I don't know if you've read those guidelines, if you have any comments to add upon that guideline.
So I think the problem is that one, the evidence for nausea, vomiting, and the cannabinoids are shaky. Like a lot of research is actually very, very shaky. There's around 4,000 articles when you put cannabinoids and anesthesia together. 3,700 are the reviews of 300 articles. So, and the other problems with this 3,700, there's a lot of supposition and opinion. Okay, I think the problem is that how do you quantify? And will that really change my management? If the patient is going to tell me, you know, I took the marijuana, I'm like, okay, how much do you take? If they tell me I'm taking 4 months, I'm going to ask him, did you take yesterday? Because I don't want you to actually be in the withdrawals 7 hours later, which is probably unlikely because the patient is literally saturated with the THC. If that's an ICU patient, that's a different story. Then I would say, okay, in the terms of the risk management, I would say like, by the time I work him out in 3 days, he's going to be difficult to control because he is going to have a withdrawal reaction, emergency reaction, God knows what else. So I think, you know, there are recommendations, but how do you translate them into the real life? I would find it very, very, very difficult. And again, what is the level of the evidence? It's C and D. C is better opinion, D is just opinion. Like all whatever I presented here is actually C minus, D minus, maybe there's 1B, okay, on the recommendation. So I would not treat this that there's any settle down. And again, the research is poor because, yeah. So try to put, so there's no research about the gun violence, right? Because some people said, we're not going to sponsor that. There's very difficult research about the alcohol. And marijuana is in exactly the same category, that you can start the research. It's going to be complicated, it will be very highly scrutinized, and everybody will ask you, why don't you study something else? Just for the disclaimer, this is not what I study, actually.
Okay, thank you.
Thanks.
Yeah, I think a lot of the problem with the marijuana, I practice in Michigan where it's legal. So, and even before that, it was medically available. So, even little old ladies that would come in for arthritic hips that were being replaced would tell me they have a card. And I go, a card? What do you mean, like a Medicaid card? Or no, a card, wink, wink. And it's like, oh, okay. So the problem is we don't make any effort to quantify what they're doing, and so some of it, I think, a lot of it is observational. So the difference between some guy who's taking a lot of edibles and he's able to get off his Keppra for seizures, great, good for him. He's obviously a little more, rather than the person who's just casual, maybe not the word for it. Some of these people are smoking 3 or 4 times a day, and you wonder how much of that is self-selection. I don't know if they have other things going on. I know a lot of chronic pain patients are heavy marijuana smokers, and a lot of them, it's always something that I ask in my pre-op, but I don't do much with that information other than just, they may have an irritable airway.
So the way I sort of learn about it, it's a loaded question to ask. So that is why another reason I don't ask. Patients volunteer. The second, I agree with you. Like, what do I do with this information? I used to practice Pennsylvania. Now I'm in Minnesota. So I understand people who go in through the snow to do the cases, no matter what. I'm like, that's impossible.
Yeah, the surgeons are the only ones who don't show up in the snow.
Yeah.
The patients are there early.
So we have the same from the New Jersey, right. and it's like people who come with the cart. I have a cart, and I'm like, okay, good for you. I really don't know what to do about it. And I think the other problem is like, even the example that you mentioned. Okay, somebody get himself off the Keppra. I still don't know what caused the more effects.
Yeah.
What is beneficial long-term effects? Because we did a lot of approval of the marijuana. It's going to be great, and I'm like, well, it's still smoke. So,
And one of my classmates in Colorado did a study, quote unquote. But he said that people that smoke marijuana need twice as much propofol for a colonoscopy. Yeah. And so the way that I looked at his methods, what he did was he gave people who smoke marijuana twice as much propofol. Well, all you've proven is that people that smoke marijuana can take twice as much propofol for a colonoscopy. You haven't really shown that it's necessary, or so to me, a lot of what we know about marijuana, or what we think we know, is all observational. It's like going back to, the idea that smoking causes bowling on Tuesday nights. Well, in the old days, when you showed up at a bowling alley, the smoke would knock you over, and that was on Tuesday night. So, it's, you have to be careful is it an association, or is it, and the other thing is self-selection. I mean, a lot of these people smoking marijuana are, it's something that you choose to do. It's not something that people are
like
forced
self-medicating.
So are they self-medicating for some other reason? So,
and the study from Colorado is a classical example that if you want to prove, you prove it. It's a little bit like ArtsNet study. If you want to show the harm, you can. You just need to design the study. The study I was showing is a study done in Europe when they conclude marijuana does cause increased demand on the anesthetic, but the study had 2 measurements, BIS and objective evaluation by anesthesiologists. I don't know what objective evaluation by anesthesiologists is, but this was the same. About objective evaluation was different. And I'm like, well, that doesn't sound like very objective to me.
Yeah.
So that's the problem with the methodology, which is...
To me, you ask all these questions, and where I practice, I have to ask about hookah, too, and they don't think that that's smoking. And I go, well, what do you think happens? Oh, there's water. I go, what do you think the water does? It doesn't take anything out of it. Smoke. You're still smoking. So, some of these people you have to really take a deep dive if you're going to ask those questions. But again, what do you do with that information? Does it change your anesthesia practice? Probably not. I use it more as an intervention to say, if you Oh, I used to smoke cigarettes, but I gave it up, and now I smoke marijuana 4 times a day. Well, that's probably worse, actually, than smoking, whatever you used to smoke. So,
I agree with a lot of observations.
yeah, I mean, I do it to get out about airway irritation, and then if they wake up funny, of course, every nurses will say, well, it's because they smoke marijuana. Well, maybe it is, maybe it's not. We have no way of knowing, really.
Yeah.
The main consideration to add to that conversation that we've seen in the peds world is if they're using CBD oil, which actually has a consistency of butter, or like coconut oil that is in its solid state, is NPO status. So if a child is receiving it, then how is that going to impact NPO status? Right after we give them 30 mils of pre-op meds and then take them right back. So.
2 questions to counter on that with cannabinoids. With regards to the thyroid, liver disease, or any of the things that we may observe might be caused from marijuana, was that any edibles, or are we also talking tobacco like in smoking form, or is it just in general the drug itself?
All of the above, and all of this is by the, so it's a 2 kinds of research, 3 kinds of research, and it's a typical research dilemma. There's some observation on the rats on the THC that got injected, and then somebody observed steatosis. Okay, how do you translate that into the clinical realm? I have no idea. There's no study which shows that if you take edibles or the THC, you have a higher risk of the liver failure, or your alkaline phosphatase will go higher. So again, there's a research observation, and how much this will translate into real life, I don't know. I think the only reason I put that slides is to sort of show quote-unquote curiosity over there. I do not believe that, for example, patients who has a hepatitis got this hepatitis because of cannabinoids, and I should change something tragically. I think this is just one of the research effects.
And I guess in respect, since we don't really know, but with smokers, we tell them, to stop a certain amount of time before surgery because they'll have less secretions. And we also say that it's reversible damage for some of these smokers that have done it. The question is whether or not we can actually do that if we see reversible effects from THC. And is there something, because there's the question of NPO status, and we have patients who use it for anxiety. And so we'll have patients that come in and have smoked at 2 a.m. because they're coming in for 7 a.m. surgery. And we don't want them to not have their daily dose of anti-anxiety in their sense. But at the same point, is this delaying with NPO? So is there anything that you can comment to whether or not we should be telling them to smoke before they come in, or not smoke, or
You're trying either to suspend my DA license or get me fired from the job, one of those two. So I would actually, if the patient takes for the anxiety, NPO effects are elusive. Let me put it this way, like nobody said that those patients has a high risk of the aspiration pneumonia, aspiration pneumonitis, or something that it could be quantifiable. The study I show is on the synthetic CB1 agonist, which shows delayed gastric emptying in the rats. Like, we're not rats, we don't use the synthetic CB1, we use the mixtures of the herbs, and how that translates into whatever is difficult to quantify. If my patient is going to be anxious because he didn't smoke, I would prefer him not to be anxious. So I would reversely say, just smoke. Okay, I had a period of my clinical practice that I valiantly tried to give all my patients who smoke marijuana the same counseling I do when they smoke tobacco. I find those discussions inherently harder to have. Like, you go immediately into how great is the drug, all this and that, and I'm like, as much as I want to be with my patients, I really don't have a 30 minutes. And plus, I already see that I will be losing in this equation. Like, there's absolutely no opening quite often. So that's another reason I stop asking. If they want to tell me, they will tell me. Doesn't impact my plan. It's a kind of difficult dilemma. You should tell them to stop. Ethically, you should tell them stop. Then if they stop, they go the withdrawal. Then it just gets complicated. Sometimes, I guess, how they say, not knowing is a bliss.
Well, please join me in thanking the speakers. And please.